couple of main hospitals. Sir's field of interest is interventional endoscopy and liver transplantation. He has been faculty in many nationalized conferences and has various publications to his credit. I invite you, sir, for your talk on hepatic encephalopathy and practical results.
May I request Professor Dr. Sujata Ma and Dr. Raja sir to felicitate our speaker, Dr. Arun sir.
That was really a fantastic talk for the results, really very eye-opening for hepatic probiotics. And it was of a longer time, and there is such a fantastic area of discussion about today. And respected professors, senior consultant, dear friends, really great pleasure for me to be here. I am Dr. Arun from Stanley. I am an alumnus of Stanley, and it's a DM in Stanley from 2015 to 18 back. And it's really great honor for me to be here once again. And I am Professor to be result. And today we all gather here to participate on the superannuation of the great professor of the Jashwan sir. And when I did my DM here, so it was such a great occasion. We all discussing every time all of the problems we are facing, most of the other things. So sir is such a humble, down-to-earth person. Whenever we have any doubts, we always go and discuss the scenario with the person. We even more comfortable with surgical gastroenterology as a gastroenterology perspective. So we very comfortable time for initial 2015 to 18, the golden era for our journey. And once again, even in this superannuation period, once again, I wish you a very, very happy, sound, healthy retirement life, and to continue all the way keep on inspiring us throughout this day. Thank you very much. And today, I don't want to take much of your time. Already we have discussed what I think. So we will be clearly addressing the major key entities what you're supposed to know about hepatic encephalopathy. We all know we'll be coming up with this kind of scenario, common daily routine practice. But how frequently we are going to diagnose? That's still how frequently we are going to diagnose them. So how do you going to diagnose? That's still a challenging task most of the time, because once the patient is going to land at the reversing of treatment, like which means the patient is going for grade 3 and 4 hepatic encephalopathy, which means very easy, obvious to diagnose such kind of presentation. But how are you going to recognize one patient with the initial early phase? For example, in covered hepatic encephalopathy, in the initial phase of grade 0, grade 1 hepatic encephalopathy, which is happening. So I will take note of the description. Hepatic encephalopathy by 1957. When you are going to look for the hepatic encephalopathy, three major guidelines you should not forget in gastroenterology. One is American Association, and apart from European Association guidelines, and the Indian Association. But basically, once the patient is going to develop liver impact, which means the patient is going to develop a liver gigantic disease. It might be either neurological events or psychological events which the sufferers or some clinical contribution to overcome. That's what the basic definition is. So, very common. There are three major entities in hepatology. One is acute liver failure, the second one is acute non-chronic liver failure, the third one is acute liver contamination, the fourth one will be your chronic liver disease. For each of them, the pathophysiological concept will be different. But we should not forget, once the patient is having acute liver failure, which means the patient may be sometimes suddenly there is evidence of liver bursting or function. It might be because of multiple reasons, acute heart failure, infective, drug-induced, so many things will be there. So, which which is happening in a span of time. The biopathy which is going to get worse and all those things if it is going to happen in the span of time, which means acute liver failure is going to take off. Apart from that, what is going to happen once a patient is going to land with illness of acute liver failure, there will be rapid ammonia intoxication will be going to develop, which is going to develop a rapid cellular edema, worsening of function, as well as edema, all those things, and which will predispose the patient to land with evidence of raised intravenous tension. And second thing will be your acute or chronic liver failure, which means the patient will be having evidence of chronic liver disease pathology. In the background, the patient suddenly develop an infection of any infection which predisposes to acute worsening of changes. In this kind of background, the patient will be having a chronic swelling, inflammation cascade which is happening, sudden response because of your systemic inflammatory response scenario which is going to get triggered on. The patient will have worsening of fevers because of your encephalopathy action. And chronic liver disease, it slowly accumulating causes over a period of time. The patient will be having worsening of changes over a period of time. So the basic thing is, if the patient is having encephalopathy, that is an alarming sign. You need to be cautious. You need to refer the patient promptly to the gastroenterologist. You need to make sure that the patient needs to go for liver transplant once the patient is having evidence of grade 3 and 4 hepatic encephalopathy. So grade 2, 1 is a prompt area to recognize such kind of presentation, because in the initial phase only you can able to decide whether the patient deserves liver transplant as an earlier protocol. Because whatever the treatment we are going to do, we all should remember that the liver is only a support part. You know, more than 1,000 functions the liver being performing, and it's only a bridge to therapy. Whatever the medical management you are going to use is only a bridge to therapy. So the final line, take out conclusion will be your liver transplant. We should not forget that. So once a patient is going for this, around 20 to 30% of overweight encephalopathy, the patient may have worsening of changes, and there is a scenario what is called as stitch, which means if you are going to place a sham, transtubular intrahepatic photosystemic shunt procedure, that will predispose the patient for evidence of around 40 to 50% patients may go for hepatic encephalopathy and that kind of presentations. Very importantly, pathophysiology, the key concept I will be addressing here. One is the ammonia site toxicity. What is going to happen once a patient is going to land up with evidence of ammonia toxicity? I am not going to show you the definition, but briefly I will be explaining. So, ammonia is the source of metabolism by various things. One by your colonic bacteria, as already been mentioned, that will be a urease conversion, the ammonia gets accumulated. Again, which will be forming a glutamate partner is going to react. Number 2 will be kidney, in which it is not going to metabolize your urine, as well as it is not going to metabolize your glutamate part, which is going to get accumulated, that will be disposed. And muscle metabolism, that's why the sarcopenia and other things which will be taking on. So once the muscle metabolism, if it is not going to get accumulated in the proper way, which means the patient is going for ammonia accumulation. So this is all. Normally, we should bypass all these toxins if it is going to get accumulated. So what's the dynamic if the patient is going to get the patient will be having ammonia cytotoxicity, which is going to be the informing effect. That is what is called as Trojan horse hypothesis. Whether any of the post-diagnosis can able to understand what is Trojan horse hypothesis? Do you have any idea about Trojan horse hypothesis? What do you mean by Trojan horse? Trojan horse is nothing but in which if any entry, if it is going to happen separate, it means the ammonia if it goes to accumulate in your astrocyte separately, which will be predisposing for the glutamate which is going to get accumulated. The cerebral defense mechanism which is going to get failed off, at that point of junction, the patient will have worsening of changes like your astrocyte swelling, blood barrier disruption, your medicaments changes, your all those pictures will be able to take on. So this is what the basic inflammatory cascade, your systemic inflammatory response, your various pro-inflammatory cascade which is going to get reacting, your astrocyte edema which is going to get happen. That should be the microclear activation. All these things will be predisposing to this. Number 2, the pathophysiology will be your gut dysbiosis. So once that's very interesting. Already the probiotic effect we discussed in detailing with our Professor Victor. So once a gut is there, what is that? So normally we have a good function of bacteria like your lactobacillus, bifidobacter, all those things. Once there is eubiosis, if it is going to go down, if the dysbiosis is going to get break off, which means there are Clostridium difficile, and apart from the other bacteria like your Rubinococcus and all those things, if it is going to enter from another species, it is going to get augmented, which means the dysbiotic effect going to get taken off. At that point, there will be evidence of leaky gut syndrome. Once a patient is going for leaky gut, there will be evidence of ammonia metabolism which is going to get impaired, water system shunting which is going to get shaken off. At that point of juncture, the patient may have worsened of hepatic encephalopathy. So this is what the basic pathophysiology, and so many other concepts like your manganese accumulation, sodium accumulation, and potassium accumulation, and apart from that basic ganglia disruption. And there are so many conceptual mechanisms like your branch and amino acids and aromatic amino acid differentiation, what's called as Fischer's ratio. So this is what so many things are being done. Initial hypothetical concepts are there for pathogenesis of hepatic encephalopathy, and we should not forget about this neuroinflammatory cascade along with your astrocytic apart from Progenous hypothesis in the background of ammonia accumulation which is happening along with the gut dysbiosis. This is what the basic pillar of pathophysiology. In brief, we should not forget how the ammonia gets trapped into your various systems and will be predisposing patient for hepatic encephalopathy. Now coming up, so you are going to get a scenario of hepatic encephalopathy, but how are you going to recognize such patients? That's very important. There are so many classifications are there in order to maintain that best evidence to be well accepted and solid, which means that from neurocognitive disorders are being identified. Use that we can able to identify your staging system. Remember, minimal hepatic encephalopathy, covert hepatic encephalopathy, which means the patient will be up to stage 1. The patient will be euphoric, agitated, and all those things. Once the patient is going for stage 2, which means the patient will be an asphyxious-like presentation, the neurocognitive disturbances, and once the patient is going for stage 3 and 4, which means the further person is stupor state and comatose state, all these things. Very importantly, your GCS, very simple, we can identify the echo, V5 as well as the M6 as well as oriented, all these things. We need to identify the GCS component as well as the and there are multiple other scoring criteria. There are 4 scoring criteria. There are establishments there, all the scoring criteria there. We should remember that these are the basic things we should not forget. Very importantly about the classification. So what is this classification? Mainly by type A, B and C. Type A, in case if the patient is having acute liver failure, that's already been discussed. B in the background of portal system shunting, and C in the background of cirrhosis. As we are frequently coming across with cirrhotic background. The patient may have a decompensation, urea ascites, use all those things. So we will be frequently coming across with C. But there are entirely different pathophysiological aspects for each and everything. As I already been pointed out, very importantly, once a patient is going to land up with this kind of presentation, we need to categorize 2 major things. Whether the patient is having only episodic hepatic encephalopathy, or whether the patient is having a recurrent hepatic encephalopathy, or whether the patient is having persistent, which means the patient will be always in an agitated, disturbed state. So, what will be the episodic? Just 1 episode in the period of 6 months. If it is going to be more than 2 episodes in a period of 6 months, which means it's more catastrophic presentation, we need to be very cautious that patient deserves liver transplant workup as early as possible. Identify. So once a patient is going to land up with evidence of this kind of events, we need to look for the precipitating factor. In gastroenterology, the precipitating factors will be very common. Sometimes the patient is having constipation like liver, which will be predisposing to urea accumulation, urea produce organism accumulation, and there will be more ammonia type toxicity, which will be predisposing for hepatic encephalopathy, or if the patient is having severe diarrhea or electrolyte disturbances. Apart from that, if the patient is having GA bleed, very common scenario in the background of CAD, if the patient is having GA bleed, what is going to happen? That large amount of blood will be acting as a separate meal for the ammonia to get the urease bacteria to get proliferate, which will be making the ammonia site toxicity to go worsening. So GA bleed, there are so many precipitating, any drug abuse, diuretic abuse, there are so many precipitating factors which we are not supposed to forget. The precipitating factors being categorized to 2 major enzymes. That's very simple. One is your nitrogenous components, another one is your non-nitrogenous components. When you are going to look into this various precipitating factors, this is there. So this is all one, we need to be very cautious. If the precipitating factors are there, we need to recognize the patient with hepatic encephalopathy precipitation which is going for grade 3 or 4 in a variety of ways, and then we can able to decide and guidelines for you. So what I discussed, this is accessibility classification, and you will list of precipitating factors like your blood disturbances, constipation, diuretic abuse, all those things. And we will discuss with this grading system. Always we should remember one conclusion it is only because of the hepatic encephalopathy. Because hepatic encephalopathy is the diagnosis of exclusion. We need to look for all possible triggers that we should not forget. We need to identify whether the patient is having any septic focus of encephalopathy or whether the patient is having any evidence of Wernicke's presentation. If the patient might be having acute evidence of alcohol intoxication, at that point the patient may have ophthalmoplegia, ataxia, or the presentation of triad. So the patient may have evidence of Wernicke's and drug abuse, alcohol, your psychiatric disturbances, your IC bleed, your focal neurological disturbances, so many other physiological factors we need to look into and before delivering this patient is having. So alcoholic hepatitis is also a diagnosis of exclusion. So we need to rule out all the possible points. Even if the patient comes with huge binge of alcohol and the patient is coming to us in casualty, it doesn't mean that the patient is having bursting of liver problems. It's only because of alcohol. It might be a coexisting fever, it might be a coexisting other infectious trigger, all the possible metabolic focus, your MASH, all these things we need to address. So clinical history, recognition, that's very important for you to recognize this kind of presentation in a prompt way. So as I discussed, it should be always a diagnosis of exclusion and various grading systems, the process of severity already been discussed, and your GCS you might be well aware of that, and briefly about the various just to identify your psychomotor function, which is nothing about it's a separate question for exam for most of the postgraduate, and clinical recognition when you are going for a practical scenarios like your presentation, you might be having discharge. That might be your psychometric health evaluation system, what you are going to see. There are various jobs that are very importantly we need to remember that number connection, serial talking, light tracing, and there are so many other investigations like your multiple investigation guidance like that. Application form that is true patterns is available and integrity control. Very important pointers I would like to point. So whenever you are going to perform on this test, we need to assess the visual-spatial coordination along with your cognitive function and your your muscle activities and all of those things, which is very important to recognize such kind of presentation. So this is what the outline about your number connection, which we need to see whether the patients are evidence of minimal hepatic, your serial touting, number connection, block design, this is what. But another important pointer is outback, which means the reversible factory and neurological sensory assessment, which we can use for your memory, visual-spatial, as well as your language and attention. So you can use this battery of scoring system like outback to diagnose. And one important thing is inhibitor control. See, it's simple thing. So you need to see X for each and every point of participation. I mean, why we think they're able to identify that. Which means if there is a delay between the patient, the target and the lead effect. Target means they need to identify the pointer correctly. The lead means in which they are going to misplace that. So at that point in time, there is a proof that the patient is going to be a pattern encephalopathy with this. So many computerized tests, true pattern. Suppose if you are writing in a chart with red color pen on ask patient just mention the word as blue means the patient is supposed to say it as red. So like that the patient needs to identify the color rather than what has been mentioned there. So like that we need to have a strict application form which will be well available as per ASP guide mentioned. This app is more recommended to diagnose such hepatic patient. And clinically, we can able to do one interesting test called critical figure frequency. So what is a critical frequency? It's an ophthalmological assessment. You need to have a small, and with that we can able to diagnose. So just give a flash of light. For example, if the flickering frequency has to maintain more than 45. If the flickering frequency if it is going to be less than 39 Hz, which means the patient is going to have a minimal hepatic. Remember this simple concept. So for example, in a tube light or bulb, it should be always flickering, which means once the flickering distance will be very fast, what's going to happen? It will be having a sustained effect. So the patient will be having only a sustained effect at that point of time. So that's how we need to recognize this critical figure frequency to identify whether the patient is having evidence of changes or minimal hepatic encephalopathy. There are not. So with this epigram analysis, you can able to identify that and we can able to diagnose this kind of presentation. And next tab, so your inhibitor control, your critical frequency, there are not. So with this epigram analysis, you can able to identify that and we can able to diagnose this kind of presentation. And next tab, So your inhibitor control, your critical frequency, your psychometric assessment, these are all the pointers we can see. Imaging, not major recommendation, but if at all if you want to do imaging, you can do a CT if you are identifying a focal neurological deficit, or if the patient is having thalamosensory impairment and other things, then you can go by MRI. And nowadays a new concept of diffusion weighted imaging, in which if you are going to look for the metabolites like tau and codeine, which is myonistat pathway, all these things, the metabolites will be releasing once in ammonia traffic which is going to take on. At that point of juncture, you can go for your MR spectroscopy measurement, in which with the myoinositol and phosphate ratio is going to be the higher side, the taurine glycinol ratio is going to be there. All these pointers we can able to measure the peaks with your MR spectroscopy, your diffusion weighted imaging. These are all the latest updates we should not forget when you are going to look for evidence of hepatic income. How are you going to diagnose minimal hepatic income? Look for the clinical pointers and subject the patient for investigation. See to that. Basic investigation is very important. Complete analysis. Whether the patient is alcoholic, so basic your AV, your CBC, LFT, RP, even electrolyte. Look for the viral pointers. All the basic investigation we are not supposed to forget, and look for evidence of ALF, ACLF, or CAD background. In the with that, we can be able to subject the patient for your psychometric assessment. The psychometric assessment is normal, doesn't mean that it's completely normal. So even if the psychometric assessment, if it is normal, there are some chances for the patient to have 20 to 30% patients still have chances to get problem. So always we need to take as an overall picture, not supposed to consider one major point at one point of time. And if you are going to identify any abnormal score, which means the hepatic income is being confirmed, as well as we need to target the patient for management. So what is the basic management? So identify the precipitating factor. So stop the precipitation factor. The patient can GAB, go for banding and other things, and other management, and put the patient right shoes, stabilize the airway, breathing, circulation. These basic pointers, stabilize for electrolyte disturbances and all those things. Assess the sensorium based upon that the patient deserves equation, guidance and all those things. So what is the basic factor? Always the well accepted molecule will be your lactose. The first type of molecule is the lactose mechanism is very important. It will be having a cathartic effect in your soda, as well as it's going to reduce your colonic pH. So what's going to happen? Will be acting on your urease producing organism, thereby forming lactic acid, acetic acid. The pH in your body will be going to come out with your lactose, and cathartic effect your gut dysbiosis will be going to be improved with your lactose. With all this basic mechanism. So what's the dose? That's important. Whether you're going to put the patient on oral or right tube. So you need to give 20 to 30 ml every second level, that's important. Now if the patient is going for grade 3, 4 NCAP, we need to give the patient where 3 level and some level and should be made with lactose every month. So to that kind of patient, grade 3 and 4 hepatic NCAP we can use. Now lactose, the best kind of molecule is still well considered. All the guidelines, EAS, LAS, DNAS, all the major guidelines accepted lactose, and next kind of molecule will be your rifaximin. So this is one basic guide, rifaximin, which is going to be a semi-synthetic non-amino acid and non-amino glycoside, which acts predominantly on gram-positive. It's 5 to beta urine subunit of dependent on RNA molecule. So 550 milligrams BD, if you are going to give your rifaximin, for a combination therapy, if you are going to use for duration, and how long you are going to use that indefinitely, unless the patient is going for liver transplant, you need to consider. And apart from that, episodic HE, there are no major guidelines, but once the patient is having recurrent HE, definitely the patient needs rifaximin for a longer duration of time, and we need to submit the patient for liver transplant first. And the two major molecules like lactose and rifaximin will be well considered, and PEG, polyethylene glycol, phospholators, enema, support, all those things we can try as a good presentation, but there might be evidence of electrolyte disturbance in your bed. Apart from that, neomycin, metronidazole, these are all other molecules can be added, but there are no major papers to document the beneficial role with your neomycin or metronidazole. Unless and otherwise, if you are going to suspect any oxidative deficit infection, at that point of juncture, you can add your metronidazole support, but there is actually no major role for metronidazole. And apart from other neomolecules like your low sodium benzoate and sodium phenylacetate, these are all the neomolecules to be considered. But one of the main pathway of infection is mainly in the ammonia pathway. So ammonia, the urea cycle, as you are well remember that the unit list of enzymes starting from your ornithine, transcriptase and ornithine phosphate, apart from that your arginine, your succinate, your fumarate and all those things, the urea cycle which is going to involve. That is the area that a unit list of molecules like sodium phenylacetate, butyrate and there are so many molecules in which you can try like a Lola, L-ornithine, aspartame. All these things we can consider along with the management guide for hepatic encephalopathy. But no single proven molecule being considered to check relation with hepatic encephalopathy. That is number 3. And probiotics has already been discussed. There might be a role to improve the urease phenomena. So your VSP well accepted because it contains almost over 8 strains of bacteria which you can be able to consider that. And probiotics alone not be considered. Probiotics and fecal microbiome transplants. That also having a significant role to nowadays look probiotics still a research area rather than considering as a direct tool of management. Apart from once a patient is going for ACL of like presentation, there might be we need to consider that for your molecular deabsorption dialysis and liposomal dialysis and so many other pathways like that we can be able to consider in the management guidelines like your so your liposomal supported paper dialysis. So many things are there. Once a patient is going for your grade 3 and 4 NCAP in the background of renal injury, ACL of presentation, multi-organ dysfunction, at that point of time you can consider this kind of treatment guideline. Very importantly, add-on treatment like your branchial amino acids, like your valine, isolation, adenine, and all those things we can add on at a rate of around 0.2 to 0.6 grams per kg, milligrams per kg per day, along with other treatment guidelines like zinc, which will be predominantly acting as a cofactor in urea cycle pathway. You can give zinc at a rate of around 220 milligrams twice daily, which is almost equivalent to 50 milligrams of elemental zinc you can consider. So there are a huge list of molecules that are in the part. The well-known molecule, your lactulose as well, rifaximin. This is one. And main thing is, before concluding, what we are supposed to find is, so investigation therapy, newer therapies like your scavengers, your spherical carbon, which will be trapping the ammonium ions, apart from the gut-targeted microbiome. New modalities are there, but protein restriction, no major role. So we can give a decent protein 1.2 to 1.3 grams per kg per day, BCAA supplementation, zinc supplementation, vitamin A, vitamin D, fat soluble supplementation, along with we need to address the patient with lactose and rifaximin. So we prevent sarcopenia, that is very important to target. And primary prophylaxis, lactose and secondary prophylaxis, if the patient have a recurrent hepatic income, we need to go for lactose or rifaximin. And before concluding, recognize the presentation early and see for the precipitating factors. Differentiate the patient whether the patient is having illness of ALF, CAD or ACLF. See for the pathophysiological core renal and what's the best type of molecule you are going to choose and whether the patient deserves liver transplant work up early. With that we can able to include a clinical scenario definitely. With this I'm happy to rest. Thank you all for patience. Any questions?
So thank you very much. I think that was an exhaustive coverage of the topic of hepatic encephalopathy because it is an exam topic for our meeting as well. And we have that many patients in the ward. Every admission day, minimum 5 to 6 cases of cirrhosis with some complication or the other. NG is one of them. So, and we have covered how they later the way that to diagnose with the neuropsychiatric aspects of it and various tests which we are not that familiar with. So is this being done regularly in your setting?
See, madam, the one problem in our scenario, see, these are all the various investigations that we have done. But during our postgraduate period, we did our postgraduate under Professor Dr. A.R. So he was very interested to see a critical bit of pregnancy. So we will take some of the patients to ophthalmology department and we have been looking for that change. But so we have done all those things, but how far it is going to heal you? Because most of the presentation we can able to diagnose in initial phase of management. Apart from that, one thing is we need to spend more and more time with the patient. Are we spending adequately with the patient? We definitely no. Even in government setup, we will be coming across, see, in a routine duty base, I still remember when I was postgraduate, multiple patients would be coming to a medicine department and every day will be coming, most of the time the patient will be on grade 2, grade 3, grade 4 NCAP. The patient may lie in the ward. because there might not be every units of bed source which is available in the ICU department. So that might be a critical source to identify all these things in the initial phase. But when we want to subject, because recognizing covert hepatic encephalopathy in European centers and all is very important, because there we have a driving protocol, occupation protocols, physical work protocols, all those things is there. So they need to recognize covert HE, because if the patient can able to covert HE, they cannot get the licensing source and all those things. But how far we are establishing these scenarios in India is still a questionable issue, and we are not still up to the mark to cope with that. But when we are going to implement that, then definitely we can able to subsequent issue for liver transplant worker as early as possible.
As I said, Miss, the load is so much that sometimes we need to bypass certain requirements that we need. And every time a person has or a patient has an episode of HE, we realize that the cognition also gets affected.
For even with the post-transplant scenario, the patient will be an intubation in the grade 3 and 4 in India. The patient underwent liver transplant successfully, everything. But even with the post-transplant scenario, the patient neurocognitive impairment, if you are going to intervene the patient in late phase, 20 to 30% of the patient, even post-transplant, there might be evidence of neurocognitive impairment will be there. So we need to address such kind of things as early. That is why recognizing the patient immediately as early as possible is very important to tackle such presentation.
Regarding protein diet, hepatic encephalopathy, so there is one protein restriction, protein creation. During the period of hepatic, can we restrict protein, protein diet?
No, sir. Now the concept of protein restriction has been completely gone. Now we need to recommend the patient for 1.2 to 1.5 grams per kg per day. Initially we used to restrict the patient for 0.5 to 1, but that from 2015 in ASIN they will remove the guidance and they will recommend only a non-protein diet. Even for hepatic encephalopathy, the protein restriction is definitely not well recommended. If the patient has severe worsening of impairment, that time even protein restriction, if the patient has too much of molecule overload and that kind of scenario we can consider, but not for achieve person.
Because our law, it has always protocol structure.
Yes.
Science be identified. The only complication is the hepatic encephalopathy going protocol.
That's very common scenario.
Yeah.
That is why the thing is.
How can you manage that one? Because dietary management. Because Americans don't take a high protein diet.
Yes, sir. Suppose, for example, the photosystemic shunt, so there are three major mechanisms. One is hydrogenic, one is naturally happening, based upon the speed of inhalation and all those things. Hydrogenic, or example, if the patient has TIPS procedure. For example, if the patient is having TIPS transducer intravenous shunt procedure which is happening, the shunt diameter will be usually the shunt will be around 10 cm diameter. So in order to prevent this hepatic encephalopathy presentation, we need to choose the small system. And so almost around 8 mm. So if you are going to use a small system size, the possibility of worsening of HE will be definitely coming down.
That but we only dietary modification.
Dietary modification definitely at the point of juncture, minimal protein restriction can be still considered.
I was also thinking about something to do with the embolization of the
BRU. So balloon retrograde transference obliteration, if the patient has a refractory presentation before the subsequent patient for liver transplant, we can consider for BRU as one of the modality for therapy. But in Indian scenario, the cost is too high. How far the patient is going to access the because these are all the digital therapy. It takes 3 to 4 lakh, the patient needs to spend BRU on 3 to 4 lakh. So this is not the problematic scenario. Now in government centers, we are doing more of this kind of procedure, but unfortunately, it's not happening in many of the centers in India.
Are there any absorbance efforts, a carbon-based?
Yes, spherical carbon absorbance. That spherical carbon absorbance are not very right. They are not just based upon your ammonia scavenging mechanism. These are all being tried, like your pan-cascade inhibitor, like your every and spherical absorbance, that kind of derivatives. All these things can be add-on. These are all under trial, but still not being proven. And even if your span, for example, your adjuvant dialysis, your MAR, all those things, these are all one station going for mercy of liver failure. Nothing of that. Ischemic involvement, cardiac, respiratory, muscular failure, at that point, you need to consider this kind of thing. But spherical carbon absorbance is an add-on, but not to be considered load as a therapy.
Thank you.
I thank you for the wonderful lecture. still no much has been said about the pathophysiology and other things about the hepatic encephalopathy. So we still rely on mainly on the lactose and the toxins kind of things. So the preventive and the supportive management and the comorbidity and the general management. That's how it goes. Is there any way that you can develop a resistance to lactose, or is there any alternative to that?
First of all, the patient, see, problem is if you are going to subject 20 to 30 ml of lactose every second hour in the background of over and gap. So that is a problem in our treatment. We are not giving honeymoon. We may be having over acidification or too much of diarrhea, dehydration, nephrotic disturbance will be happening. At that point, we will be restricting the dose. Are we sincerely trying to every 2 to 3 hours of dose of 50 to 30 ml or 20 to 40 minutes? Absolutely no. We will be giving only very minimal, but we can go up to 120 to 150 ml per day. But lactose enema, as already pointed out here, in some level we can try with lactose enema. But there might be having an alternative with your polyethylene glycol. We can still consider correlation or support of polyethylene glycol. That might be having a equal potential role, but you cannot consider for the longer duration of treatment because the patient may have worsening of GI, IDS and other complications may precipitate with your polyethylene glycol. More dehydration events can precipitate. So lactose and PEG can be considered an alternative, but the best kind of therapy to act on various metabolisms, various four major pathways like your colonic area, apart from hepatic, gut, metabolic modulators, still lactose is the first line of therapy for all the major guidance to be considered. Combined with lactose and PEG, as of now, no major papers are there to recommend. Lactose and rifaximin has been well proven, and rifaximin various trials. One classical trial, what is called as small hepatic infection, in which they have proven that lactose and rifaximin they will be having a significant potential role. But lactose PEG, as of now, I am not very aware about that. But PEG can be used as an alternative to that. They can give an alternative, but isolated combination therapy, what is the role? Unless if the patient, the initial dose, if it is not going to respond, already the patient is going for resistant of the therapy. The final line we need to take forward is hepatic and get further line.
Any questions from the audience?
Constipation, if there is impacted stool, this is lactose for work actually. This impact is just be evacuated.
That's what the lactose enema at that point of time should be done. See, even stage 3 flu enema is done with recommended role rather than considering the only one line. Sarcopenia is always trigger pathway because the nutrition, frequent snacking, that is what is important. Every 4th hour we need to maintain the salary to do. So that's what's called as the very problematic scenario with the variant of alcohol. Because alcohol will always give you empty calorie syndrome. The patient will be taking too much of alcohol, so that means that they are consuming more of the calories. Definitely no. That's because mostly empty calorie ratio. So what is going to happen? The patient may have worse liver function. The patient may have sarcopenia, even acid problems. So that kind of patient, in order to prevent that, we be subjecting them weight reduction and support as an add-on. So sarcopenia, your resistant training, your exercises, all those things along with your BCAA supplement in the background of your zinc supplementation also to prevent, because these are all the muscle nutrition pathway which is going to get active. So zinc, along with your BCAA can be added on to your therapy for to prevent the sarcopenia and other. Sarcopenia is definitely a potential trigger for the patient to go for vascular achievement.
What dangerous? Right thing is constant physical activity, exercise. Unless you exercise, the body won't be utilized. Balance. Physical activity is best stimulus for the liver than any other medicine. Unless there is physical activity, water, amount of supplement, water and protein we give, it will not be useless actually. So first get the importance of the physical activity, walking on this. Then only good. Because this is the business world, probably the business has to go. Protein something like this, 19, all these things and all. But probably that's not right is important. But most important thing is physical activity, nothing else.
That's why the recently it was not commercialized. So many of you know that there is something called a whey protein that is extracted from cheese. People say that gym or wherever it is, like they sell tons of whey protein or the very chicken powder, very they sell them. Like all these things are like the natural way of building muscle and building up muscle. In fact, that will do more on by doing mature kidney and warming the kidney. That's why sarcopenia is a thing that has to be addressed. So for all systems.
Thank you very much, sir.
Thank you, sir, for those valuable insights.